everyone, and welcome to Communicating with Confianza, Health Literacy Eco Series. My name is Dr. Raquel Romero, and I'm going to be the Eco Facilitator for the session today. This session is brought to you by Health Confianza team in collaboration with the UT Health San Antonio Super Hub, the YMCA, the South Central, EHEC, and the University of Texas at Austin. Please let me start by saying that Health Confianza is a community-wide health literacy program that aims to provide health literacy education, training, resources, and workforce development for Bejar County and the surrounding areas. Confianza is the Spanish word for trust. Our team believes that health literacy is critical to transform health and to achieve health equity for all. With the goal of increase health literacy in our communities, these sessions were carefully planned to equip with tools and skills to all of those that attend the sessions. And we may have different reasons to join those sessions, but there is one consistent thing that I believe brings us closer together, and this is a desire to deep understanding and health literacy. And very important, each session builds upon each other. So I invite you to explore what we have offering to you for the following sessions. And thank you again for your trust in us. For those that are new for the ECHO platform, ECHO stands for Extension for Community Health Outcomes. It's a virtual telementoring stage that is designed to create connections between community and subject matter. So the ECHO has a few core elements. We start with welcome, and then we have didactics, and then we have a case presentation. And please remember that no personal health information is allowed to share at any point. So what is personal health information, or PHI? Is DOB, so date of birth, addresses, and appointments, etc. So now, before we go to the introduction for our Confianza team, there are a few technical points that I need to mention to you. To help with our attendance records, please enter your name and your affiliation in the chat. You can also use the chat later for asking questions or share your comments. And we promote interactions in our sessions, and we love to see everyone's faces. So if you're able and comfortable, please share your video, particularly in the discussion part of the session. So now I would like to go with the introduction. So let me start with our team. We have Dr. Melanie Stone.
Good afternoon, everybody. I had to see what time it is. Good afternoon on this Friday. Happy to have you all join us for our continued ECHO series. Really happy today to have Dr. Bazaldua, my close colleague in health literacy. I'm Dr. Melanie Stone. I'm assistant professor in our Department of Family and Community Medicine at UT San Antonio, and I direct our Community Engaged Learning program, and I am co-director of Health Confianza. Thank you.
Thank you, Dr. Melanie. So now that you mentioned Dr. Bazaldua, so let me then ask Dr. Bazaldua to introduce herself, and she's going to be the didactics presenter for today.
Yes, hello everyone. Good afternoon. I am happy to be here, and I'm glad to see all of you here joining us in this quest of helping everyone of our patients understand. Thank you.
Thank you. Thank you so much, and thank you for being with us today. Thank you for all you do. And for our communities, we have also Dr. Rosenfeld.
Hi, good afternoon, everyone. I'm Jason Rosenfeld. I'm an associate professor in the Department of Medicine. I am also the co-director of the Health Confianza program, along with Dr. Melanie Stone. And before I hand over the talking stick, I just wanted to put out a quick save the date and a note for help. Our team has been finalizing a webinar series for our K through 12 nurses in the region, very specific for them. It's entitled Integrating Youth Mental Health into School Nursing Practice. That series is going to be launching officially on November 11th. We'll be offering that series kind of twice each time, a 4-session series. Each session offered twice, once at noon, once at 4. We're just asking for you to help get the word out to our nurses so that they can participate in this important webinar series. So thanks.
Thank you very much for sharing, and yes, please spread the word. That's a very good opportunity. We have a Corinne Reyes. Corinne Reyes, please. It's still here in another square.
I'm still here, Dr. Romero. Hi, guys. I'm Corinne Reyes with YWCA San Antonio Chief Programming and Health and Education. Happy to be here with you guys today.
Thank you. Thank you very much. The case presenter for today is Maria de Leon. Maria de Leon.
Hi,
or
everybody.
Grace de Leon?
Gracie De Leon from Health Confianza. I'm Community Outreach Coordinator.
So it's Grace. Okay, I'm gonna put that in my notes. Thank you so much. Well, I think as I mentioned, all the team members. So as a quick,
Did you put the?
sorry, I clicked the wrong button. Thank you very much. As a quick reminder, towards the end of the session, our team will send you a link for the continuing education credits and the evaluation of this session. And these sessions are possible because of you. So your feedback is very important for us. So finally, I would like to mention that ECHO is all teach, all learn environment. So we encourage you to share your experience, questions, and insights through our conversation. So with not more from my end, I will pass this space to Dr. Bazaldua for the presentation. Dr. Bazaldua, when you are ready.
Okay, I will share my slides. Let's see.
Very good. I can see the presentation very well. Thank you so much.
Okay, great. Well, good afternoon, everyone. Again, it's a pleasure to be here. And I always enjoy talking about health literacy and making sure that our patients understand what is going on with them in terms of their health care. And, a few months ago, I was at a restaurant and I saw this little 8 or 9-year-old little boy, and he had a T-shirt that said, "If you want me to pay attention, talk to me about baseball." And I thought that, maybe our patients would have a similar sign or a T-shirt that would say, "If you want me to understand, keep it simple." So I want to make a T-shirt like that for our patients. And so brief objectives for today, we'll define what plain language is, briefly talk about the Plain Writing Act and its mandates, review useful clinical techniques, and then talk about some resources available that might be helpful to you. A few years ago, a couple of our colleagues within the university health system, they asked professionals like you and myself to share scenarios where poor communication got in the way of a successful outcome. And they developed this training guide called Scenarios for Success, a training guide for healthcare professionals. So I just wanted to share a couple of the examples, and these are real patients. The pictures are not, but the scenarios are real. One of them is Mrs. Washington that had a yeast infection. She was prescribed a medication, and she was told by her doctor to take it with yogurt because it would help with the yeast infection. And when Ms. Washington went in for her follow-up appointment, a strawberry was found in her vagina during the vaginal exam. And of course, the yogurt was intended to be taken by mouth. This scenario is about Mr. Cherian, relating to medication symbols. So Mr. Cherian was given a medication to take once a day with food. The medication bottle had a picture of a hamburger on it to denote taking it with food. But Mr. Cherian did not take the medication because he could not afford to buy a hamburger every day. So he thought that that meant take it with a hamburger every day. So plain language, so what is the definition? So it enables patients to find, understand, and use health information to make informed decisions to then take appropriate action. So it must be clear and concise. So use simple, direct language that gets straight to the point. So no beating around the bush. It should be audience appropriate. So match the language level and content to your specific patient population and their needs. It should be well organized. Present information in logical order with clear headings and visual structure. And most importantly, what do I need to do? So make it action-oriented. Tell patients exactly what they need to do, when to do it, and how to do it. Again, don't assume that they know, so make sure that it's action-oriented. And I think that by now you are convinced that there is no doubt that plain language matters. We know that plain language directly reduces medical errors and improves treatment adherence. We know that patients who receive clear health information are 2 times more likely to follow treatment plans and report higher satisfaction scores. It is especially essential for patients with limited English proficiency. The other point to remember is that there is a universal benefit to using plain language. It applies to written and spoken communication, and it benefits all patients, regardless of their education or language background. So in summary, plain language improves outcomes. It improves emotional health, resolution of symptoms, and overall functional status. Moving on to the Plain Writing Act. This was enacted in 2010, and basically it mandates that federal agencies use clear communication in all public-facing documents. Examples of agencies that are impacted by this act are the CDC, the Centers for Disease Control, the National Institute of Health, the Food and Drug Administration, the AHRQ, the Agency for Healthcare Research and Quality, and many other federal agents like the CMS. So what are some examples of what this might impact? So example documents are patient letters, any patient letters and forms, website contents and notices, new or substantially revised materials, public guidance and educational resources. And so overall, the staff must have training. So implementation requirements, staff must be trained. There should be a dedicated web page for guidance and follow federal plain language guidelines overall. Key provisions in an updated section, section 1557, they state that they must have qualified interpreters at no cost. And in fact, I just used this 2 days ago. And we actually had an in-person interpreter that's usually better than an iPad or a telephone. They should have accessible formats for patients with disabilities so they can see or hear. We should accommodate for that. Telehealth inclusion in language access requirements and vital document translation for limited English proficiency patients. So all these are the statements and the mandates in this national action of 2010. In this slide, I'd like to share some of the clinical techniques that might be of use when communicating with our patients. First one is Ask Me 3. So we should encourage the patients to ask 3 main questions. The first one is, what is my main problem? What do I need to do about it? And number 3, why is it important for me to do this? Sometimes, even if we tell them what it is, what they need to do, if they don't understand why it's important, they may not have a motivation to do what we're asking them to do or suggesting to do. The next technique is a teach-back method. I'm hoping that we're all familiar with it. I use this not only with every one of my patients, but several times within my one visit with the patient, making sure that they understand. And so it's using a chunk and check method. So give small amounts of information and then ask the patient to repeat back in their own words. And I did a study a few years ago about medication information, and we did the teach-back loop. And eventually we taught the patient until they got the information correctly. And the range of how many times we had to do this teach-back loop ranged from anywhere between 1 to 6 times to get that 1 point to the patient. And the average, we found that we had to do this at least, it was 2.5 times before the patient got the information correctly. So on the average, we have to make sure we do this teach back method 2 to 3 times for them to get this 1 point. So it's evidence-based, so that's why I like to use it, and it's very practical. Third technique is using everyday words, and that's what we're here today, to remind us to make sure that we're using words that our patients will understand. So replace medical jargon with common terms that patients understand. Now, I always tell my learners that when I was in school, I had to go to a Latin-based course to learn about all the Latin languages that we use in medical care. But when I go talk to my patients, now I have to reverse that and go back to my plain language growing up, talking to my parents and my grandparents. So we have to, it's a different language altogether. Just I'm a bilingual provider. And so I speak in English to my English-speaking patients and Spanish to my Spanish-speaking patients. And so I switch back and forth. And similarly, we also have to switch to a plain language, not just to a different language kind of patient, but to all of our patients. And also limit key points. So focus on 1 to 3 main messages per conversation to avoid information overload. And sometimes this is hard for me because I get patients as a consult, and there's so many things that need to be addressed. I try to do that, and sometimes I break this, limit key point kind of general rule. But in general, we should try to keep it simple and minimal. And fifth one is confirm language preference. So ask patients their preferred language for medical discussions and arrange interpretation as needed. So I do have a lot of patients that are bilingual as well. Some of them prefer Spanish better, some English. And so when I get to the room, I ask them, what language would you prefer to speak in? And sometimes it's, whichever one, whatever. And if I have a learner, I choose English so that the learner can understand if they're not bilingual. But at the end of the day, it seems like we always end up speaking Spanglish. So, sometimes we have to interpret anyways for our learners or for the patients or backwards. So, but in general, I try to speak the language that they prefer. And in terms of numbers, in medicine, I'm a clinical pharmacist by background. So I'm always helping patients choose medications and helping our physician providers learn about medications and using this versus the other one. And we use a lot of statistics. We talk about numbers needed to treat, numbers needed to harm, the percent of patients that got better. It's a lot of numbers. And so we just basically need to keep it simple. And so when we, sometimes I'm thinking, does the patient, is it nice to know, or is it something that the patient needs to know? So I have to just, kind of decide, is this patient really just, do they want to know, is the medication work or not? Is that all they want to know, or do they want to know a little bit more? Sometimes I like to make sure patients understand the importance of medications. So they do struggle with percentages and complex statistics. So transform numbers in formats that support informed decision-making and that also reduce anxiety. So rather than saying the percentage, so you have a 15% risk of whatever this issue is, that might create confusion and fear without really any clinical context. It would be better to use words like, out of 100 people like yourself, 15 might experience this side effect, while 85% or 85 patients will not. Or if there's a 50% kind of story, and there's 4 people in the room, I say, well, if we think about all the people here in the room, there's 4 of us. So that means that 2 of us will have this side effect if it's a 50%. So try to make it in some way that the patients can understand easily and simply. So again, use a 13 out of 100 instead of 13%. It seems that patients understand the context better. And when I teach about medication labels and what to put on the labels, something that we've learned in the literature supports this is, rather than saying take 1 tablet twice a day, and say 1 ONE and twice TWICE, instead of using the words, use the numbers. So take 1 tablet by mouth and the number 2 twice a day. So using the numbers in the context of the label or the information that you're providing seems it's easier for patients to understand because they can identify the number 1, 2, 3 as opposed to having to read THREE. So that's easier for the patients. The other recommendation is to use the same denominator when you're comparing. So use, for example, 5 out of 100 and 12 out of 100 instead of 1 out of 2 and 5 out of 10. Whatever the denominator, just make it the same. So don't compare apples to oranges, but basically oranges to oranges and apples to apples in the same denominator. And if you can, pair an icon or simple chart with one clear takeaway message. So if you're sharing numbers, is it something that you can draw, so that the patient can have a visual? A lot of us are visual learners, so can you make it visual? Yesterday, I was having a conversation with a patient about their elevated blood pressure. The blood pressure is too high. And she was saying that she checks it at home, and she says, sometimes my blood pressure just goes all the way up and down. It's just kind of, hard to keep it controlled. And what she was doing is when the blood pressure would go up, she would take an extra tablet. And then when it was down, she would skip it, or it's too low, she would skip it. So she was kind of messing with her medication, which is really not appropriate. So I took a piece of paper and I documented, this is a happy place where your blood pressure should be. Sometimes it's here and that's okay. Sometimes it's okay higher here, but as long as it's in a happy place, you should be good. But if it goes further than that, then that's a little more dangerous. And then we talked about being consistent with her medications. And at the end, I think she felt better about where she was and how to take her medications. So visual supplements is helpful. So now we'll talk about just a few things or resources that are available. There's a lot out there, but just a few things that I wanted to share. There's this plain language thesaurus that the CDC provides. And basically it converts a difficult medical word into a plain language that our patients might be understanding better than that one. So these are just some examples. So abdomen, instead of saying abdomen, you can use stomach or belly. Cardiac, you can use heart. And sometimes patients say, I just came back from the cardiology office or clinic. So in that case, I know I can use cardiology instead of saying the heart doctor. And instead of using a myocardial infarction, you might say a heart attack. CVA or cerebral vascular accident, you just had a stroke. Benign, it's not cancer. Discontinue, discontinue, I thought that's a plain language kind of word, I thought. But you'd be surprised that patients really, sometimes they don't know what this word discontinue means. So you stop this medication. Instead of contraceptive, use birth control. Exacerbate. That's like 4 syllables. That's a long word. So use worsen. And then I have these other words that I thought I'd put out here so that you can kind of think. You don't have to unmute yourself or write anything, but just think about how you would explain A1C or how have you explained A1C. To me, that's probably one of the worst medical terms because it's not really a term. It's just, what I tell patients, the A1C, don't worry about what that stands for, other than it's a blood test that gives us a number that tells us how well your diabetes is under control. And then I explained to them, in your case, you want a target of less than 7. And I was talking to a patient just yesterday, her A1C went from 9 to 12. So I showed her in the lab in the computer, and she was very astonished that it went up that high. And so she committed to doing better about her nutrition. What about injection? How would you say that? A shot, perhaps. Inflammation. Some people will say swelling. Do you have any swelling in your legs? Immunizations. You're due for all these immunizations. Rather than using that word, use vaccines. And hypertension is another word that I thought, that's pretty simple and people use it all the time. And I thought, no, I use it all the time. My providers use it all the time. But, there's a video that I recall where they're talking about hypertension and they're asking patients in the streets, what does that mean? And some people say, well, that means when you're hyper, you're just like you just had a lot of coffee, you're hyper. Or someone else said, maybe that's when you're just tense, you're just too tense. And so don't assume that patients understand every word that we're saying. So high blood pressure, and even blood pressure. What does that really mean? And when I talk to patients about their hypertension, I usually, we call it the silent killer. So I explain to that because they usually say, I was fine. I know you said my blood pressure is high, but I feel fine. And so then I talk to them about other complications. So just speaking in this plain language is often not enough. You need to explain a little bit further. And then chronic, what does chronic mean? So it's a lifelong condition or condition that's going to last for a long time. So this thesaurus might help with that. Write clearly. So 6 essential moves. So lead with action. We talked about action being important. Start with the main message or required action, then provide supporting details. Use you in an active voice. So writing directly to patients. So you should take this medication instead of the medication should be taken, blah, blah, blah. Number 3, short sentences and clear headings are important. So break complex information into digestible chunks with descriptive headers. I review medical journals like the Journal of Family Medicine, pharmacotherapy journals. When they, we write manuscripts, they submit it for peer review. So I'm one of the peer reviewers, and you'd be surprised how many times I see like 3 or 4 different ideas in one long run-on sentence. And so I just, in big red letters, I said, nope, break it down into 3 or 4 sentences because that's just too confusing. I have to stop and read it several times, and it's not, even for our medical providers, we want to make it, simple to read and understand. Number 4, list and white space is important. So use bullet points and adequate spacing to improve readability and comprehensions. You'll notice that a lot of my slides have lists, so it's easy for me to present, easy for you to see. Number 5, use 12 to 14 point fonts with strong color contrast for accessibility. And the font, as I get older, that becomes more and more important. So earlier, in fact, I think it was this slide that I switched it to from, it was like a small 12 to like a 16, because I thought, I have space and I can make it bigger. And number 6, validate with real patients. So not just readability that we can do in Word or in our AI tools, but test it with real patients, real users. And this is my last slide here. Basically, just some resources that you can use. So the CDC has a clear communication index. Another one is called Everyday Words for Health. The AHRQ has a health literacy toolkit that I've used in the past, and that was very helpful for some of my presentations and using it in my clinic every day. And then Health Literacy Online. So a lot of these resources, they are free and they're available for immediate download and implementation. And more recently, in the last probably 2 or so years, I've been learning more about artificial intelligence and how I can use it in my clinical practice and with my learners and also with my patients. So earlier this morning, I wanted to share with you I thought, I'm going to share with them about using ChatGPT as well. So I asked my friend ChatGPT, I said, please convert this statement into plain language for a patient. And the statement was, you just had a myocardial infarction and you will need antiplatelets to minimize your risk of thrombosis. And this is what ChatGPT converted it to. It said, you just had a heart attack. You'll need to take medicine to help prevent blood clots so your blood can flow more easily through your heart and arteries. So with my AI friend here, I will end my discussion and I'll pass it over to the case presentation. And thanks again for being here and joining us and helping our patients understand.
Thank you so much, Dr. Bazaldua. Thank you for this. It's very, very informative. I really like what the transforming numbers into the format to support clear communication. Thank you for sharing that. And we have a couple of questions in the chat. Dr. Rosenthal, I think I saw disappear my text, but you have very important question. You would like to articulate that, Dr. Rosenthal?
Yeah, thanks, Aurelio. As you were presenting that kind of table of terms, I got to thinking about the use of the words positive and negative with test results and how when people hear that, it can become confusing. Do you have any tips on how we can best communicate and help people interpret what those mean?
Yeah, basically what they want to know is that, well, is that good news or bad news? Right. So I'll just say whatever well, it's negative. That's a good thing, Mrs. Smith. That means you don't have this infection. Or it's positive. Unfortunately, you're positive for whatever it is. So using good news and bad news might be a better way to understand. And then, of course, if it's bad news, kind of making it a little more digestible for the patient. That's great. Great point, though. I see that all the time.
Yeah, it is complicated because normally positive is good, negative is bad. So, but in this case, I think it's very important to use this clear message, and what you said also, short sentences, right? That helps for all of us to understand better.
As you were asking that, I was thinking, how about if I look at a little, a pregnancy test, positive or negative, that could be good or bad depending on what you're hoping, right? So that might be a little trickier.
Yeah, again, to what happened after the positive or the negative, the context of that, I think is a very, very important. Very good point. And thank you for sharing. Annette, you also have some comments you want to articulate. Do you want to elaborate a little bit more?
Sure. Hang on. There we go. I fully understand the idea of using plain language. We've tried to do that in all of our communications. I use ChatGPT a lot to generate language at a 6th grade reading level. But my question is, when you're talking with a patient, how much do you think that you should incorporate teaching in with the plain language? I mean, so that they would know if they hear this word, this is what it means. Because in a perfect world, we'll all use plain language, but we know it's not a perfect world.
So how much do I teach? I learned from one of our, health literacy experts that, and I use that in teaching my physician residents too. I think about what information do they need to know versus information that is nice to know. For my patients, I only teach them what they need to know. Do they really need to know this? Yes. Okay, then let's discuss it. So you kind of have to make that distinction. Is it nice to know versus it's need to know? They need to know that they need to take their medication for their blood pressure every single day. Do they need to know how it works? Maybe not. For blood pressure, I said they need to know what the complications are so that they know the importance of that. And I had a physician the other day, and I said, how would you explain to the patient about the importance of hypertension? And she starts talking about, I would explain about the vessels and the arterial dilation. And she starts talking about the pathophysiology of it. I'm like, well, maybe, that's nice to know, but do they really need to know that? What they really need to know is that if their blood pressure is out of control, they'll get a stroke.
Sure. I think I wasn't clear enough in my question. I was thinking about teaching some more basic things like terminology. And the example I gave was, we were talking about defining chronic in a plain language way. This is a lifelong illness. How important do you think it is that the patient also knows you might hear other people call this a chronic illness? So if you hear that, that's what this means.
I minimize how much I do that. And, chronic is kind of tricky as well because, patients often ask me, well, how long do I need to take this medication? And I remember responding to one patient, I said, for the rest of your life. And that was taken very negative. He's like, oh my gosh, she was not happy with that response. So I need to be kind of softer about that. And so, yeah, only if I need it. In chronic, yeah, to be honest, I usually don't because I spend a lot of time with the patients already for their specific needs, that anything extra is just probably too much. But if it could be maybe a separate session just to talk about some general things, but it's not easy in a clinical scenario.
No, it's not easy, particularly when you receive a diagnosis and then the treatment, right? So how you can go over that, because it can be overwhelming. In fact, can be. Dr. Stone, I see also some notes in the chat.
Yeah, no, I was just responding to Annette's question, but I did want to bring up, I think, a couple of things in regards to plain language. One is, Oralia mentioned this in her presentation, but using universal precautions. What sometimes happens is providers will make assumptions about their patient because maybe their patient seems like they're highly educated, or maybe they're even in the health profession, but you start talking to them about their cancer diagnosis, and it's not a language that they're familiar with anymore. And so, always keeping in mind using plain language is a universal best practice, no matter who your patient or client is. Now, if they start, if they start using the jargon and the technical terms, then you know that they are, at a level that maybe you can talk to them about that, but don't make that assumption right away. And then my second point was we didn't really cover cultural context when you're using plain language communication, but words and phrases can be interpreted differently with different languages and also cultural settings. And so you might start using an analogy or, maybe some humor that you think is appropriate here in the US, but maybe the person is from Afghanistan and that's not, like they take that completely differently. And so you want to make sure, just to be very, again, simple and clear, and understanding where that person's background is. There is a story that Oralia and I often tell to our students, and I'm not sure if this is actually true or if it's health literacy legend, but apparently a mom who had a toddler daughter in California went to the pharmacy to get her daughter's prescription for Dilantin for her epilepsy. And she looked at the pharmacy label and she read the words ONCE. That's how many times she was to give her medication, the medication to her daughter. So she read ONCE. Guess how many times she gave that pill? How many pills she gave to that daughter? What is ONCE in Spanish? All right, Corinne's saying 11. So it's 11. She gave apparently because no one explained, to her in her language, her preferred language. And so she just read it and assumed it was 11. And unfortunately, the legend is that the daughter overdosed and died. And so, these are real considerations when you're thinking about language. It's not necessarily as straightforward as we sometimes think.
Yeah, this is very important. Thank you for sharing that. I also see Isabel says, would like to add that even with the same language, different countries also have different meaning for words or cultural preferences. Because it can be interpreted differently. Yes, Dr.
That's a good point. Early on in my career, I was asking the patients, I'm a Spanish speaking person. And so I was asking her about her, whether she had breakfast. And I said, I asked about, do you have an almuerzo? And she would say, I forget what the story was, but the confusion was that she calls almuerzo lunch. And to me, almuerzo can be desayuno or or almuerzo, both breakfast. And so it was confusing. It had to do with her insulin dosing. And so that's a good point that even within the same language, same word might have different meanings. So we have to be careful about that. And eventually I said, well, how many meals do you have? Okay, how about meal number 1, meal number 2, and meal number 3? And then that's when we were able to tease out that little difference in terms of almuerzo versus desayuno.
Yeah, because the first time that I heard that, I also was thinking, I needed to think twice, like what is that means, knowing Spanish. But I know different countries, even in the same country, you can have a different area where they say it differently. And then Rita says sometimes there is so much information that needs to be explained to the patient that it is best to keep it simple because you may have limited time, or they may not see you again. Right? It can be overwhelming. Yeah. Thank you so much for putting your comments in the chat. Please keep sharing those. And thank you again, Dr. Bazaldua, for this wonderful presentation. And thank you all for all the questions. So now I would like to move to our case presentation. Grace de Leon.
Hello, everybody. The case is about, I was at a health club meeting presentation, and a cardiologist had gone to do a presentation to the group about heart conditions, various heart conditions. And through the presentation, her emphasis was sharing your symptoms, knowing your symptoms, and sharing your symptoms with your provider. And on all the conditions that she would talk about, that was her emphasis, sharing, knowing your symptoms and sharing the symptoms with your provider. So after the presentation, a lady approached me, and in Spanish, she said, I want to know why I was in the hospital receiving intensive care. I did not know she was at the hospital at that time. She caught me off guard, surprised, because to me, I always saw her healthy. And so I was like, oh, I did not know you were in the hospital. So I asked her to explain why she was in the hospital to begin with, and why she was asking the question, how long was she there? And she was a couple of days there, and she says, I don't know. And I go, what is your paper? Did you get any paperwork? And what does it tell you? I asked her. And so she could not remember if she had received any paperwork herself on that. So she was concerned about that. So I asked her for the symptoms that led to her seeking help, going to a hospital. And she said there was headaches, dizziness, and she still was not feeling well. So that's what the case is about. That she could not remember what happened to her, why, and she had nothing to fall back as to why was she there. So I suggested to her that usually tell her if she could find the paperwork, and then that they usually refer her to go talk to a doctor, her family doctor, her provider. So I suggested she call her doctor and to say that she just recently was discharged and that she was still not feeling well, by explaining and telling them what the symptoms she's having right now. So I also reminded her that her doctor could request her medical records, and he could review it with her, and also discuss what happened, what was the treatment, the cause for her hospital stay. I also suggested to her that to write down, like the doctor had mentioned at the presentation, to write down any symptoms that she has right now, and if it's related to any kind of activity that she was doing when she felt the symptom, and any questions and concerns that she may have, and to take someone with her when she goes to see the doctor, and also to ask for a Spanish translator, because she only spoke Spanish, so that everything that was explained, discussed with her, and reviewed with her, and any paper that was given to her could be explained to her prior to her leaving the office. So what went well? She received a possible solution to her health needs by, follow up with her doctor, and she repeated the suggestions I provided to her about writing down prior to her visit, or seeing the doctor again, what she needed to do, as writing down her symptoms and her questions. And the presentation, the doctor presentation, triggered her memory to recall symptoms, and she was reminded to write them down. So that was a good thing that as she was talking to me, she was telling me, oh, I remember this. Oh, so I go write them down. So what went less is it could have been better if her husband was there. He's usually with her, and at that time he was not with her. So to reinforce the information that she was receiving about writing the symptoms, preparing herself before the doctor visit. The language barrier was, it seemed to be like she was not receiving the information that could have been better for her to understand what was going on with her. And it seems there was no follow-up from the hospital after her visit, because she did not mention that anyone had called her. to follow up. So the question I have is, at discharge, do they have to provide health information, paperwork to them discharge, and how is the language addressed for people who do not understand the medical terms in the English language? I mean, I know the patients are sometimes want to get out, from the hospital, they're ready to go home, but how much time is taken in explaining it to them? And providing the information to where they can understand and the importance of follow-up too.
Yeah, very, very important question. And yeah, and too much information at one point. Thank you so much for sharing the case. Is there any question, any comment, any thoughts?
I don't know the answer specifically to that question. It's been more than probably 10 or 15 years that I've worked in the hospital, but I think the answer is not enough for this particular case, right? And this seems like this discussion we should have with our colleagues in the hospital system, starting with, the lowest man in the totem pole to the highest man in the totem pole, because this needs to be better. And I just by having a discussion here with you guys, I think we're making small strides, but Melly and I have been doing this for probably more than 20 years, and I feel like we're just barely touching the surface. So a lot of work needs to be done.
That's true.
Yeah, thank you so much. I read this message. This is a great case to study. Thank you so much. I haven't seen so many similar situations with patients. This is from Mrs. Neros, and I see Ms. Maldonado. I see your hand. Do you have any question, comment?
About Grace and the other person that did the presentation, that's very good. I type of person that I had to take medications, and sometimes I forget if I took them or not, especially at bedtime. And if I don't recall taking it, I had to wait the following day. And it's hard. It's very hard. So I understand somebody taking 11, that's a lot. And accidents do happen. At the same time, we had to remind these people that they are responsible if anything happens to the kids, including to the dog, because I never imagined that my daughter's dog would eat my medicine. So we had to rush her out to the hospital. She did chew my medicine. So it's very dangerous. As case health worker, I always advise to use, if you have kids around, to use the medicine. They have childproof. But for animals, at the end of the day, I would never imagine that dog would eat the medicine. I just put it for 1 second and turned like this and took it.
Yeah. Thank you, Ms. Maldonado. Thank you.
Yeah, thank you. Thank you.
Thank you. No, thank you very much for and actually that brings a very good a question. What can be the recommendation for, and we may all be in this situation, forget to take medication? What can be the recommendation?
Well,
okay, go ahead.
I was going to say, I do this every single day, and we can probably have a whole nother discussion on this. But I usually try to tailor it to the specific patient and their lifestyle, what's going on. And we can usually find a solution, probably like 98% of the time, but it's kind of tailored. So one example was a patient that was forgetting to use her insulin because it was in the first floor in the kitchen. Her bedroom was upstairs. She was told to take it at night. She was upstairs in bed and like, oh, I forgot my insulin and I don't want to go downstairs. I'll just take it tomorrow. The solution was she didn't know that insulin is good for 28 days out of the refrigerator. So take it, keep it in your bedroom. So things like that. It has to be individualized.
Thank you very much. And I've been seeing your work in my past. So I know it's requires a lot of communication with patients, and you do very, very good. Thank you so much for doing that. I have also Ms. Ramos, Dr. Ramos. I see your hand also. Are we there, Ramon? Yes,
Hi. So sorry.
No.
I just have two quick questions, two quick comments. Thank you for this very lively conversation. I had been a patient in the last 6 months in different hospitals in the Brentford, San Antonio, and Mayo Clinic. And I tell you, the different levels of health literacy is really striking. Like Dr. Bazaldua mentioned, there's still a lot of work to do. But just a quick thing about the discharge I was discharged on Sunday by the nurse. They gave me a bunch of papers and my husband to sign. That was it. This is your discharge order, sign it. And I said, no. Tell me what is in here. And they didn't have the time. So finally I went to the manager. I just had to get my hat on. So I went to the manager, she sit down with me. I said, I really need to understand the medication and I need to understand these instructions. So again, there is a lot. I think this is a cultural thing. I think that in the whole hospital, from the moment you walk in, or the office, from the moment you walk in to the moment you leave, is health literacy at all levels, like it's been mentioned before. The second thing, I'm bilingual as well. My patient with the Spanish, when I speak Spanish, sometimes I have to say what it means to you, like you mentioned dinner, because I'm Puerto Rican, but when I talk with Mexican background or from Venezuela, even food means completely different. For me, China is orange. For other people, China is the country of China, or it could be something else. So when I translate I've been doing a lot of translation lately for different activities and updating. I always ask somebody else who is in this group, can you help me? And I learning so much because I thought it was great. And then they say, well, there's another way to say this. So I just want to make those two comments. There's a lot of work to do. It's a cultural thing. I think because I taken this so seriously, I can take my opportunity to say to somebody, this is a better way to say this. Can you simplify this church order so I can understand? And again, they didn't know I was a physician. They're just another patient. Thank you anyway for the conversation.
No, thank you so much, Dr. Ramos. I know we have been having this conversation in the past, and we just sometimes laugh because there are different ways to say just the same thing. Thank you so much for sharing. And I think Ms. Daisy Rita has a point in regards to the paperwork. Do you wanna elaborate a little bit more your comment?
Yes, when I go to patients' home sometimes and after they have been discharged, I'm sorry, they have information about their condition and everything, but there are so many patients know that they haven't even looked at it or they feel intimidated with the amount of information, no? So that's part of it. And sometimes the language is not at the level that they understand, but that has been my experience. That is a lot, and they are trying to figure out what to take, get back to the doctor. They have been told to not take certain medications that they were taking before, and so all that is overwhelming, and then on top of that, they are confused many times.
I have a couple of questions or comments or points about a couple of things that you've said. When we discharge patients from the hospital, and I see this all the time, they were taking medications before the hospital, they make changes during the hospital, and then they say, take these at home, but they don't explain, well, which ones do I stop? Which ones do I restart? It's very confusing. So lucky for the patients that see me afterwards, we are able to tease that out, but all the other hundreds that don't, it's not a good situation. And patients, another point is that patients, even though they know how to read, they choose not to. I had a patient just yesterday, it was her blood pressure medicine. She was taking it twice a day, but the bottle said take once a day. So I said, can you read this? And she read it, take one tablet by mouth once a day. And she's like, oh, I guess I'm taking it twice a day. I guess I don't read anything. So, we need to, so kind of going back to what I think was Annette talking about, taking the opportunity to educate them. I was a foster parent, and before I got certified as a foster parent, I went through all this training of how to be a foster parent and this class and that class and certification here and certification there. And so my thought is that when the patient becomes a patient in the healthcare system, we need to teach them how to navigate the healthcare system and how to empower them to ask questions. And I know that's a big task, but I think that would be helpful from the beginning when they become a patient. Okay, and then kind of a separate encounter for education on how to read the medication labels, how to empower them to ask questions of provider, kind of like what you did, Ms. Ramos. You said, okay, I don't understand, please. You were empowered to ask questions. So there's a lot of work to do, and I'm just glad that we're starting somewhere.
Yeah.
May I have one more quick comment,
Yeah,
Dr.
Dr. Ramos? Yeah.
Yeah, so my husband is taking IV therapy on the PIC line, and I think this is really amazing. They put very simple how to get the PIC line, and they take pictures, and I just know exactly following this, and they put this number really big in the front. I thought this was a good example about good literacy. Instead of giving me a bunch of papers, they give it this. So my husband can really look how we're following his IV treatment at home. Critical, because if I mess it up, obviously there will be side effects. So I thought this is a good example.
Very good. Thank you for sharing. Yeah, we are very visual, and that helps a lot to review even the recommendations that we receive, perhaps at the discharge. Dr. Rosenfeld.
Yeah, I just wanted to take a chance real quickly before we wrap up here to underline and highlight a point that Corinne had made in the comments about the value and the power of community health workers. And so first to Gracie, your case, thank goodness you were there and you could help empower that individual and kind of help her fill in gaps and help her ask questions that she maybe wasn't empowered to ask or didn't know to ask, and just, you know, make the advocacy point for any of our healthcare partners in the room that this is where the power of the CHW can come in, is that upon discharge, in addition to the paperwork, connecting somebody with an individual like a community health worker that can go deeper into the paperwork and the follow-up and the next steps. And the evidence around this workforce from a health literacy perspective, and to Dr. Stone's point about changing the system, is robust. I mean, there's so much data now about reducing bounce backs, reducing visits to the ER by pairing individuals with community health workers, whether they're in the clinical environment or in the community environment. And I'll just say that UH here locally has a few programs like this for individuals with comorbidities as well as some chronic illnesses, so that upon discharge, they have somebody catching them and then helping them navigate the system. So I just wanted to kind of highlight that as a systems level intervention that has been proven effective and that we need to do more of as folks in this healthcare system.
If I may, Dr. Rosenfeld, I'd like to add just one more level, because yesterday I saw a patient that had a provider. She works with them, you know, Monday, actually every day, almost 40 hours a week. It's a full-time job. But out of all the 20-something years that I've been practicing, I've never seen a home provider as efficient and useful and caring as that lady. And I'm hoping that in our bigger system, we can actually train our home providers as well, so that they can take care of. There's some providers that say, oh, I just cook for them. This lady she went above and beyond, and I think we can do better at the provider level as well, just like we are with our community health workers. They're all very vital.
Yeah, thank you very much, because I think we'll talk in another session about the empathy and the compassion. That is very, very important. And the field of support at the time of the discharge, I can imagine that along with understanding the lines, it's important to feel that. Dr. Stone, do you want to make a summary of the recommendations for this, please?
Well, I think we've covered a lot of it already. I think Oralia gave us some very concrete communication techniques and steps to use. And then I think Gracie helped us understand about the importance of the system in which our patients are having to navigate, and the usefulness of community health workers and making changes to our organizations. You know, I'd rather not put all of the burden on the patient because it's not worked. Doing that over the past 25 years has not worked. We need to actually change the system in which they have to navigate their healthcare system. But other than that, I think some excellent points were made in the chat.
Thank you very much, Dr. Stone, Dr. Rosenfeld, Dr. Bazaldua. Wonderful presentation. Ms. De Leon, thank you for the case, and I invite you to think about another possible case that you can share with us. Please think about that and reach out to us, and we can share this case, and we can learn all together through this session. Thank you, Corinne. Also, thank you everyone for putting that in the chat and help with the conversation, Dr. Ramos. Also, thank you very much. So thank you for the discussion today. That was an excellent discussion. And we want to see you again in our next session in November the 7th. I have here in my notes. Also, for the continuing education credits, you see that in the chat. And until the next session, just please be safe and take care of yourself and enjoy this weather. Thank you very much.
Thank you so much. Great echo.
Bye-bye. Thank you very much.